Welcome to this Q&A, and this Q&A has a very special topic. We're going to talk about the great forgotten, which is male fertility. And I think for so many couples who have been trying to conceive, often they feel that all the burden of the investigations, exams, treatment is on women, but men are 50% of this equation. So today we have the great pleasure of speaking with Dr. Sergio Caballero from IVF-Spain Madrid. Welcome, Dr. Sergio.
Hi, thank you. Nice to be here.
Dr. Sergio, do you find that this is a common problem, that a lot of people find that male fertility is not really well investigated, or maybe even in general population, they feel that maybe it's not a man's issue?
Yes, it can be looked that way because mostly in fertility clinics, we tend to examine and treat the female factor the most, at least. But it is not exactly that way in reality. At least male factor is involved in 50% of couples that are trying to conceive and don't get to. And we can estimate that it affects 20% of them as an standalone factor, and the other 30% it coexists with the female factor. But it is, of course, as you said, it is a 50-50 kind of.
Yeah, and I've read a lot of things in the news saying that male fertility is also worsening. So is that maybe we should do more to talk about male infertility and raise awareness that men need to be assessed as well?
Yeah, that's also true. There is a classic study from I think it's the 60s or the 50s, and the parameters that are extrapolated from that population are much better than the ones that we see in everyday samples in the semen of patients of today.
So basically, my husband's grandfather had better fertility than my husband's.
Well, we can't know that for sure, but as an estimate, as an extrapolation of the population in that study, yeah, it could be possible. Yes, maybe it's the environmental factors as chemicals and everything, but it can be that way. Yes.
And maybe we should try and make a distinction between what infertility, subfertility, sterility is, because they all mean different things, don't they? And of course, different prognosis, different treatments. Can you tell us a bit about the difference between infertility, sterility?
Okay. Well, I think the terms are really intertwined among them. And I think also the meaning can vary depending on the country and language. And in Spain, for example, the classic definition of sterility means that a couple is unable to get pregnant after a year of trying, and infertility means that they can get pregnant, but that pregnancy never reaches a live birth. Therefore, they suffer a miscarriage. So that is the distinction, or at least it was, because there is a movement towards equate the meaning of both terms. And there is also a movement towards abandon these terms at all and just use subfertility, because both sterile and fertile have like such strong and negative connotations and a sense of irreversibility that most of the times it is not true. And so a movement towards a kinder term that would be subfertility is right now in place.
Yeah, so it's more common for men to be subfertile as opposed to be completely sterile. Yes,
it all depends on the origin of the subfertility or the infertility, as we want to call it. So the male factor, as we refer to when there's a problem with the sperm, it is a term that is really vague, and it includes a lot of different diagnoses. For example, it is not the same just finding a minor abnormality in the seminogram, in the spermiogram, than having had both testicles removed surgically. In the latter case, the prognosis is horrible. Thankfully, it is just such an extreme case that it's not usual at all. It's virtually non-existent, but it serves to illustrate that different origins may have different prognosis.
That's such a good point, because I know here in the UK, HFPA reports causes of infertility, and they have ovulation disorders or hormonal disorders, different factors for women, but then they group male into just one male factor. And
yes,
different things that could be wrong on men as well, just like for women is not just one.
Sure. And I think that is because the men are not studied in such depth as the women are. And so as we don't know the cause of the male infertility, we tend to say just male factor and disregard the specific cause that triggers it. But it is just like when we say something is idiopathic, just a fancy term to say that we don't know exactly what is going on underneath that problem. And that happens a lot with male infertility. Most of the cases, well, maybe not most of the cases, but many more cases than today could be diagnosed if a proper study would be made upon these subjects.
And so what are the most common causes of male infertility?
Well, as of right now, the most common would be idiopathic, which is to say that we don't know the cause exactly. But among knowable causes, there are quite many, actually. Maybe the most common would be varicocele, which is an enlargement of the veins surrounding testicles. There are also infections, there are chromosome defects or hormone imbalances that can trigger a lower quality in the sperm. There's a wide range of possibilities, actually. We need to strengthen our study. And
so how do we diagnose those? I imagine that for hormonal imbalances, they might need blood tests, or varicocele, they might need to have an examination. Can you tell us a bit about the diagnostics process that men should go through?
Okay, yes, sure. The first and most important step in the diagnosis of any illnesses should be the medical history. Okay, just by asking the right questions, we can get to know, or at least approach ourselves to the situation in a better way, actually. Even maybe just ask yourself, is the patient having problems ejaculating, or does the patient has any disease that could be related to an anatomical abnormality in the genital area, such as cystic fibrosis, or has he ever received chemotherapy during infancy? All those questions can help us get to the diagnosis in a faster way and in a more accurate way, actually. But of course, medical history alone usually doesn't get the job done. And we need also to perform different tests. The most basic one, and the one that we always need to use, is the spermiogram. Okay, with the spermiogram, we analyze the spermatozoids in the semen, and we analyze mostly the concentration, the motility, and the morphology, but other aspects as well. This is the most basic test, and depending on the results that we get from the spermiogram, we can then decide if we want to perform other tests. I would say the most important one after this would be the genital examination by a urologist, but also the scrotal ultrasound or the transrectal ultrasound. We can perform 2 genetic tests or hormone testing via blood samples, and a lot of other tests, like sperm specialized tests, such as the fragmentation test, tests that focus on the not the morphology, motility, and concentration, but on a molecular aspect of the sperm.
Yeah, and so is it true that even if some of those samples, simple semen sample, if everything is okay, maybe some problems might still be present when they do the DNA fragmentation testing.
Yes, yes. When it is true also that the more problems we find in the basic examination, the more problems we find with concentration, motility, and morphology, the more probable is for the semen to have a high grade of fragmentation of the DNA. But that DNA fragmentation can also appear without any problems in the basic spermiogram.
Okay, so it's almost like men should have all of these tests done even before treatment, isn't it? It's like the woman has...
Well, it's a delicate aspect of the treatment, and there's always what we call a sterility of unknown origin. Maybe we perform all of the tests that are possible to perform, and nothing comes out, and still the problem persists. And maybe there's something we haven't yet discovered that could help us in the future. And I don't know if performing all battery of tests would be appropriate in every case. I think maybe we would have to select or at least filter better who we test and how we test them. But yes, in many occasions, we could find that a test that we wouldn't be thinking of performing help us get to a diagnosis. Yes.
And Dr. Sergio, we have here very difficult to pronounce names: oligospermy, astenospermy, teratospermy. Can you tell us in simple terms for our listeners, what do these mean when they see the report on their sample and they see these weird names written there?
Yeah, I can try at least.
Yes.
Yes. So oligospermy is defined as either a low concentration of spermatozoids or a low total number of them. Okay, either one, it can be called oligospermy. The thresholds, the cutoffs in the last update, which has come out this summer in 2021, are below 16 million per milliliter or below a total number of 39 million. Okay, and that would be for oligospermy. For astenospermy, it doesn't refer to the concentration or to the total number, it refers to the motility. Motility of the spermatozoids can be classified into 4 categories. Okay, they are rapid progressive, slow progressive, non-progressive, and immotile. Only the first 2, rapid progressive and slow progressive, are the ones that we're interested in. And we want our sample to have more than 30% of the spermatozoids in these 2 categories. If
we want them to be moving.
Yeah, we want them to be moving.
Yes.
If any sample has below 30% of spermatozoids moving progressively, we call that astenospermy.
Okay.
And for teratospermy, it's a really complicated word. The prefix terato comes from the Greek word that means monster, and so it refers to the morphology of the spermatozoids. Okay, so we can see in the sample spermatozoids with a huge head or with 2 tails. All those are abnormal spermatozoids. And we should bear in mind that just as little as a 4% of spermatozoids that appear normal is enough to consider the sample normal as it is. And even when we have below that 4% of normal spermatozoids, then is when we call it teratospermy. Then even if that's the case, it's quite difficult. Yeah, 4%, it's too little actually. But even if we have below that percentage, 3% or 2%, the outcomes, the results after performing assisted reproductive techniques are quite good. So it is not as important as the motility or the concentration.
Okay, brilliant. And when patients are diagnosed with any of these problems, I imagine that the options to resolve them are different as well. And maybe should we even try to resolve the cause? So for example, if a patient has a varicocele, shouldn't we try and resolve that first? But sometimes I imagine that we need to try something more invasive. Can you tell us a bit about the treatment options that are available?
Okay, so for every patient, I would always recommend a healthy lifestyle. This always helps. Disregarding the origin of the infertility. This consists in healthy diet, regular exercise, avoid drugs, tobacco, alcohol, illegal drugs. All those things would be always appropriate. But then if we got to know the origin of the infertility, as you said, maybe if it was a varicocele, surgery would be appropriate in this case.
Yeah.
And the same if the patient had a vasectomy performed in the past, maybe we can surgically readaptate the tubes that transport the semen. And maybe if surgery is not the appropriate treatment, maybe there is an infection, then we can use antibiotics. Or if there is a hormone imbalance, we can provide hormone replacement. So the treatment, it is always according the cause of the infertility. We need to get that study done before, and then we can decide the treatment. It varies deeply depending on the cause.
Yeah, and even if a man doesn't have sperm in the ejaculate, as long as he's producing sperm, can't we just collect it and then use it for treatment as well? I think all the situations that you were saying where it's truly impossible to have any kind of treatment will be very rare cases, isn't it?
Yes, but even if we don't see any spermatozoid on the sample, sometimes we can get to the testicle by a biopsy and reach out for a few of them that are still in testicles. Okay, that can be done. And in other cases, when we don't know what the cause of the infertility is, and we just see the alterations in the spermiogram, what we do is optimize the selection of the one spermatozoid that we need to fertilize the egg. And we have different techniques in the laboratory that the embryologists use every day to select the best spermatozoid possible among the sample, among the ones that we have in the sample.
And Dr. Sergio, if you could give one last advice to men who are listening to this Q&A and are thinking, maybe there is a problem, maybe I haven't been checked, or maybe I've done one of those at-home sperm tests and it doesn't look good, what would your advice be?
My advice would be to seek counsel of any experienced doctor in male fertility. Okay, maybe start by a basic examination, a physical examination of the genital area by an urologist, and then continue from there, looking for his advice or her advice to how to follow on, what the next step should be in the workup diagnosis process. Dr.
Sergio, thank you so much for answering our patients' questions.
Thank you.
It's a real pleasure to have you here today.
Me too.
And I hope you have a nice day.
Yeah, thank you. Have a nice day, you too.